Our next speaker is Marian Simka from Katowice, Poland. Marian's going to speak to us on the hemodynamics of CCSVI.
Okay, so more about ultrasound. Thank you very much for a kind invitation for this outstanding meeting. Excuse me, I have another presentation in this computer. So if you, could you change here? No, on screen was okay, but in this laptop there is a presentation by Dr. McDonald. May I ask you for help here? So of course, all of you know Professor Zamboni. At least you have a photo of him, and his discovery of venous problems in multiple sclerosis has shed new light on this problem. At the moment, we defined CCSVI as a functional structural abnormality in the veins draining the central nervous system, and these problems are usually found in internal jugular veins, also in azagos, and in some of these patients also in brachiocephalic veins. For the time being, the role of intracranial veins remains undetermined. Maybe these veins play a role, but we are not very sure about it at the moment. And of course, Doppler sonography at the moment is the main diagnostic test to assess CCSVI, both before the procedure and the clinical research, after the angioplasties and so on. What can we see with ultrasound? Going back to the physiology, as Professor Becks have already presented, blood flows out of the brain mostly to internal jugular veins and vertebral veins system, but this outflow route change dramatically depending on the body posture. In the supine position, blood outflows mostly via internal jugular veins, while in the upright position, mostly via vertebral veins. Why? It's not about, as we think now, and it's not about active regulation. It's just about the basic physics. The blood or flow of the fluid depends mostly on the difference in pressure in different pathways in the case of these jugulars and vertebral veins. The parameter which is important is this one, is the radius. In case of vertebral veins, this radius does not change dramatically, but in the case of jugular veins, which are collapsible, they change the radius depending on the body posture. Why does it happen? It's dependent on the so-called transmural pressure. Transmural pressure is the pressure difference between pressure inside and outside the tube. And in the case of internal jugular veins, when a person is in upright position, whether standing or sitting, due to gravitational forces, pressure inside the vein goes down, while the external pressure, which is due to pressure executed by muscles, soft tissue, remains mostly unchanged. and in the upright position the transmural pressure, this difference between pressure from outside and inside, goes negative, and therefore such a vein collapses. When such a vein collapses, its radius goes down, and of course consequently resistance goes up, and its increase in resistance is because it depends on the radius and the force power of the radius. This resistance goes dramatically up, and most of the blood is shifted toward the vertebral veins. Of course, in this patient, sometimes we observed also such localized collapses. At the moment, we don't know what is the reason for these findings. Maybe there are just areas with increased external pressure. Maybe, as Dr. Tucker has proposed, it depends on the so-called standing waves, but of course it should be discovered in the future. So going back, so we have two main flow patterns in supine and upright position, and we think that in a case of lesions, of obstructions or other problems in the veins, this flow patterns changes, and we can detect them by means of Doppler ultrasound. So is it correct? These are so-called old Zambonis criteria. There are 5 of them. Is reflux in internal jugular veins or vertebral veins, is a bidirectional of flow in intracranial veins, is stenosis of internal jugular veins, absence of detectable flow in the veins, and so-called negative delta is the difference between cross-section area in the supine and upright position. And these criteria were published in the first papers coming from the Italian team. Of course, there were further publications, and some of the authors confirmed these Italian findings. Buffalo team was found that they are only partially positive, but of course you know about some negative studies. Importantly, all these papers did not use precisely Zambonis criteria. They were slightly modified. So you may say, okay, if the authors were following this Zambonis recommendation, they should found this problem as it has been described in the first Italian paper. But this year, there's a very new publication coming also from Italy, from Rome. I think that this is a very good study, very good paper. They followed directly these Zambonis criteria. They used the same machine, the same protocol, and so on. But they found no difference between multiple sclerosis patients and healthy controls. They found the same prevalence of positive and negative parameters. No difference. So maybe we should modify this this criteria. And indeed, in March this year in Bologna, there was a meeting of International Society for Neurovascular Disease, and there was a consensus meeting on the protocol how to perform ultrasonographic examination, and some new recommendations were accepted. And here are new criteria. Importantly, this intracranial vein assessment has not been included because this examination was thought to be very difficult to do, and also a special machine should be used, which is not widely accessible. So this new criteria is reflux in the internal jugular veins and the vertebral veins. This criterion is similar to the old Italian one, but is not the same. Stenosis of internal jugular veins is almost the same criterion. Absence of flow and negative delta. But the problem with all those sonographic criteria is that, firstly, they were tested in a manner that there was assumption that CCSVI exists in the multiple sclerosis, while in a non-MS individual there is no CCSVI. So if you look at the majority of the studies, they are tested multiple sclerosis patient against non-MS patients, and the difference between two groups is calculated. But most likely this assumption that CCSVI is MS is wrong. So I think that this approach is not correct. On the contrary, at the moment there is no paper published which were comparing sonographic findings against catheter venography. And still the catheter venography or catheter angiography, as in the vascular world, is regarded as a gold standard, irrespective of some weakness of these tests. Is still a gold standard. So we decided to evaluate all these non-invasive tests against catheter venography. Is our new accepted study, and we plan to examine 150 MS patients and 50 controls to do in MS patient non-invasive tests, is Doppler sonography, MRV and neck air plethysmography, and compare these findings to catheter venography results. And also we plan to perform this non-invasive test in healthy controls. And here are our preliminary results regarding Doppler sonography in MS patients. At the moment we have results of 49 patients, so nearly 100 of internal jugular veins were assessed by means of Doppler sonography and catheter venography. We decided that pathologic venographic findings should be as follows. So any of these findings should be regarded as pathologic venous. Venous outflow slowed down, which means that the injected contrast stayed in the vein at least for one cardiac cycle. Reflux is a reversed flow direction, so you injected the contrast, but is not going down to the heart, but is going up to the intracranial veins or the vertebrae or so on. Prestenotic dilation of the vein, but associated with a slowdown outflow or a reflux. Outflow through collaterals, no outflow through the veins. This is obvious sign of a pathology. Hypoplasia or narrowing, but again associated with slowdown outflow or refluxing. Intraluminal structures, or web septum and so on, again compromising outflow, and of course complete occlusion of the vein. So all these signs I think you can agree that they are obvious pattern of abnormal pathologic vein outflow. And how reliable are the so-called Italian criteria? So if you were regarding at least one positive sonographic criterion, sensitivity was very high. But look at the specificity of this test. Again, positive predictive value, quite good. Negative, very poor. If you were looking for at least two positive criteria, all these numbers are not very satisfactory. Perhaps these new criteria were better. Nope. Look at this specificity. For at least one positive criterion, you look at two criteria, again, these numbers are not very good. So, is sonographic assessment of this vein reliable? I think yes, but we need new criteria, we need more data, and we should know what to look for. So we must not ignore the problem that this Doppler sonography has some limitations, and we must work hard how to find out exact criteria to know that this vein in a multiple sclerosis patient or the other patient, a healthy control, is with good flow or not. So for sure we need more work, and we should not be satisfied with current criteria. Thank you very much.